This Week in Virology, the podcast about viruses, the kind that make you sick. From Microbe TV, this is TWiV, This Week in Virology, episode 1201, recorded on March 14th, 2025. I'm Vincent Racaniello, and you're listening to the podcast all about viruses. Joining me today from College Station, Texas, Jolene Ramsey.
Hello. It's 85 degrees here. It's nice and sunny, kind of like a summer here. The daffodils have all started blooming in my front yard, so it's lovely.
Here it is decidedly not summer. It's 5C here in Chelsea, so we have a way to go. Also joining us from Madison, New Jersey, Brianne Barker.
Hi, it's great to be here. I'm rather surprised that Vincent and I have rather different weather. It is 58 Fahrenheit here, so 15C.
Oh, it's a big difference.
Right.
Let me look again. Maybe I'm in the wrong city. Hang on. Yeah, it's 5C, Chelsea. That's where I am. Mostly sunny, 5 Celsius. Wait, sorry. That's the low for today. Currently it's 14C. You're right. There you go. We are similar. Also, all right, so we have, that doesn't bode well. We have a special guest for you today. He is Adam Ratner, a pediatric infectious diseases physician in New York City and author of the book Booster Shots. Here we go. The Urgent Lessons of Measles and the Uncertain Future of Children's Health. Welcome to TWiV, Adam.
Thanks. Great to be here.
And I noticed there's a broken syringe on the cover here.
Yeah, it's a syringe, it's a crayon, it's a bunch of stuff.
Oh, look. It's also a crayon. Yeah, I didn't notice that. And was that your idea?
No, sadly, that was a clever design person's idea. I had nothing to do with it, but I love it.
I love the people you got to quote here. You got Chelsea Clinton, Paul Offit, I don't know, Perry Class, David Oshinsky, of course. I don't know, Matt McCarthy, and Peter Hotez. That's pretty good. Did you give suggestions for who to get
Good
quotes
folks.
from?
I did. I reached out to, I think, all of those people.
That's cool. Good
Yeah.
for you. I just don't like superbugs as a title. I'm sorry. I don't like referring to them as bugs. Because bug is something else, right?
It's true.
If you like these programs, we'd love to have your financial support to continue them. We don't do ads, as you know, and we are a 501c3 nonprofit, so all of your donations would be federal U.S. tax deductible. Microbe.tv/contribute. Well, I've known you for a long time, Adam, from back at Columbia, but why don't you give us your history? Tell us where you started.
Sure, absolutely. I grew up in New York City. I went to college at Yale and then medical school at Columbia, which is where you and I first met. I left for a little while to go to Children's Hospital of Philadelphia to be an infectious disease fellow and then a postdoc for a while at UPenn, and then came back to Columbia, which is where we re-met each other to start a lab and be faculty there.
At Columbia, did you have Dixon for parasitology?
I did. That was fantastic. I remember it well.
You mentioned that you started a lab at Columbia. What types of things does your lab work on?
So I do mostly congenital and perinatal infections. I know I'm on TWiV, but we do a lot of bacterial stuff in the lab, mostly group B streptococcus. So everything from mouse models of perinatal transmission of group B strep to a lot of genomic epidemiology now.
We should have you on TWiM to talk about your research.
Yes.
That would be cool. We'll get you on that podcast. No, at CHOP, did you know Paul Offit there?
I did. Paul is a good friend and a wonderful mentor.
Yeah, so we do a podcast with Paul, Beyond the Noise, which is great. Love that. And so you've been doing infectious disease. You treat kids. You're a pediatrician. You do some research. Why a pediatrician and not other things?
Because kids are so much better than adults, of course.
Well, actually, dogs are better than all of them, you know.
That is true, but I don't think I would be a good veterinarian.
Yeah, kids are fun, but then it's also sad to see them get sick, right?
It is, but it's fun to help them get better. I went to school knowing I wanted to do infectious diseases and not
Mhm.
knowing whether I wanted to see adults or kids, and then that became abundantly clear.
But you say in the book that the other kinds of medicine are too fast-paced for you, right? You like to be able to sit back and think.
I do. Infectious diseases is good for me that way.
Do you know Daniel Griffin, by the way?
I don't.
Because he's been, maybe he came after you left. Yeah, I think he came in the 90s, and he of course does a podcast, a clinical update podcast with us. But he's also an infectious disease doc.
Excellent.
I do like how you talked about infectious disease as being a discipline that's about solving puzzles. I thought that was perfect and explained perhaps why many of us also like the field.
Yeah, I just adore it. It is perfect for the way I think.
So why did you write this book? You got plenty of other things to do, right?
I do have plenty of other things to do. We had this big measles outbreak in New York City in 2018 and 2019. And I had seen a handful of cases before then, one or two during my training, just returning travelers, and then a small cluster up at Columbia when I was there. And then all of a sudden, during this outbreak, we were taking care of 4 or 5 kids with measles a day. And it was this huge shift. It was super interesting to me because it was something I had kind of filed in my head under solved problems. But now then I was dealing with it every day. And it made me think about the anti-vaccine movement differently. It made me realize the incredible differences between how the parents of these kids viewed vaccines and how the grandparents who chose to vaccinate their own kids, the parents of the child I was seeing, and how they viewed it. And it was eye-opening for me in a number of ways. And so I started digging into the history of measles, which I think is super interesting. And then, of course, that was 2018, 2019. And then what came after 2019 was 2020. And that sort of changed everything again, because all of a sudden we had this new crisis and we were debating things like public health measures, school closures, masks, and eventually talking about vaccine rollouts and vaccines for kids. And I kept seeing echoes of what we should have learned from measles in what we were dealing with COVID. And that sort of again shifted the way the project went.
So you started back in 2018?
I started in 2019. After the measles outbreak was over, I was like, I couldn't get measles out of my mind. And so that was when I started digging into the history and being like, I should write a book about measles. But then, it became a book about measles and the anti-vaccine movement and COVID and lots of other things.
Hard to escape the anti-vaccine movement with measles, right?
Yes, it is.
So obviously there's like these two aspects, but in terms of the disease, most of us still haven't seen really what measles looks like, fortunately. So can you tell us what it looks like when you have a case of measles, a typical case?
Sure. So the first symptoms that kids get when they get measles are really nonspecific. They could really be due to anything. It's some fever, coughing, runny nose, red eyes. Sometimes they have pain in their eyes when they look at the light. And then, if you know to look for them, there are these little spots in the mouth called Koplik spots, which were discovered by a pediatrician in the 1800s as being pretty specific for measles. But mostly those get missed. And so you've got a kid with, upper respiratory symptoms and some fever, and it could be anything. And then after a couple of days of that, you get the rash, which really is what tips most people off to the diagnosis. And the rash starts on the back of the neck and then kind of moves to the face, down onto the torso, and then out to the arms and the legs. And then it fades in the same order that it comes. And kids are miserable for about a week. And then for most kids, for the uncomplicated cases, then they're better and they have lifelong immunity to measles, and that's great. That's not the problem. The problem is the sort of smaller percentage of kids who will go on to have pneumonia, which is about 5 to 10% of kids. A lot of them get hospitalized, and we're seeing that in the West Texas outbreak now. Mm-hmm. About 1 in 1,000 kids will get encephalitis or swelling of the brain, which can set kids up to develop blindness or deafness or seizure disorders. About 1 in 1,000 kids with measles will die which tragically we've had one death in the Texas measles outbreak now. And then there are longer term complications in small numbers of cases. There's subacute sclerosing panencephalitis, SSPE, which happens in it's the estimates vary, but it's probably about 1 in 5,000 cases that go on to this progressive neurological disease. So it has for most kids, it is not dangerous and they recover over about a week. And then in the smaller percentage of kids, there can be horrible outcomes. And because it's so contagious and so prevalent in the population when people don't vaccinate, before we had a vaccine or now in places where people don't vaccinate, we do see those bad outcomes.
One of the things that you do really, really well in this book that I was so impressed by was the way that you highlight and interweave social determinants of health. Do those sort of lead to any variation in what you see with measles, or what kind of determinants might lead to that variation?
Yeah, I think this is something that kept coming up in the history of measles, which is that what we would now call social determinants really matter. And it was true, if you look back in the late 1800s, early 1900s, you start to see people from kind of well-to-do parts of society starting to write about measles and think about measles as just part of normal childhood. It was something that every child got, and it was not a big deal at all. And at the exact same time, you have Jacob Riis, who's looking in the tenements in New York City, writing how the other half lives, saying that, hey, measles is a disease that on the avenues, which is to where the rich people live, is something that they make light of, but here in the tenements, it kills left and right. And he describes families that lose multiple children in a single measles epidemic. And so those differences have been there for a very long time. And I mean, we still see this today. I mean, in the West Texas outbreak, we've had one death, and it is tragic, and no child should be dying of measles anywhere in the world in 2025. But go ahead.
We've also actually had an adult death in the outbreak.
Yeah, that is true. But if you look globally, we still have about 10 million measles cases a year and about 100,000 deaths every year. Mm-hmm. It's just they're not here. They tend to be in places where it is harder to get vaccine there and where it is less well reported. So I think those social determinants are still very much with us.
Well, adults also can get measles, right?
Absolutely. Anyone who is not vaccinated and hasn't had measles before can. If you look at the distribution of those 100,000 deaths, though, every year, it's mainly unvaccinated kids. Yeah.
And can adults also get these rare complications like pneumonia, encephalitis, and so forth?
Yep. So those are more common at the extremes of age. So the youngest kids under a year or two of age, and then adults are at higher risk of those as well.
Okay. So we have, in the early 60s, 2 vaccines were developed, right? An inactivated and a attenuated vaccine, correct?
Yeah, just like Salk and Sabin for the polio vaccine. So same battle being fought. There was the classic, which was better, the inactivated polio vaccine or the oral polio vaccine. The answer was, as you know better than anyone, that they did different things. And for measles, though, there was a very clear answer to that question, which it took a few years to figure out. And that was that the live attenuated vaccine worked very well, and the inactivated vaccine did not work nearly as well. So both were licensed in 1963, but by the end of the 1960s, the killed virus vaccine was not being used anymore.
It's interesting because one solution does not always apply to everything else, right?
Sure.
We see that all the time. mRNA vaccines are not for every virus. Inactivation is not for every virus. So you shouldn't assume that it's going to work.
Yep.
Right. And the attenuation process itself wasn't perfect from the beginning. There were those side effects that they had to kind of work through.
Yeah, which is something I didn't realize going into this. Like, I sort of thought that there was the one live attenuated vaccine that was licensed in 1963 and we were still using it. And that's not true. So the first version of it caused fever in about half of kids, which, it is not the most serious side effect in the world, but still, if you give a child a vaccine and you have a couple of days of fever afterwards, the kid may have to stay home from school, parent may have to take off from work. It's not an ideal situation. And they dealt with that by giving the live attenuated vaccine along with a low dose shot of gamma globulin, of essentially purified antibodies. And that helped with the side effects. And the vaccine was still immunogenic. The issue was now you're talking about having to license two different products and having to give two shots for, what's essentially one vaccine because you couldn't mix them in one syringe. And so it all got very complicated. They then came out with a more attenuated version of the measles vaccine that is what we use now in the MMR vaccine.
So I have a few questions about the MMR vaccine. So is it shed from people who get it? Because the OPV polio vaccine, as you know, is shed.
So no, it's there are warnings that is theoretically possible. And I suppose if you had someone who was living with someone who was incredibly immunocompromised, someone who had just undergone a bone marrow transplant or something like that, then that's something that you might worry about. So the vaccine, the measles vaccine is live attenuated, so it replicates. There's a viremic phase that I think is essential to immunogenicity, and then in a small percentage of kids you get a rash afterwards. But even if they have the rash, they're not contagious. And I don't know of any demonstrations of secondary spread of any of the three components.
I would think we would see that in these pockets of places where there are many kids who are not vaccinated with kids who are.
Yeah. No, and I have not seen it. I haven't seen reports of it.
So the anti-vaxxers make a big deal that the side effects of measles vaccines are horrible. What are the side effects?
That is not the case. The side effects of having measles are horrible. It's about 5% of kids get fever at this point, so it's a tenth as likely as it used to be. The fevers are generally not high. When you look at thousands and thousands of kids, there is probably the side effect that people worry about most is there is probably one additional febrile seizure in children for every roughly 5,000 doses. And when you contrast that to a 1 in 1,000 risk of dying from measles, it's a much, much lower risk. About 5% of kids get rash, and this happened in my family. One of my sister called me because one of my nieces had gotten the MMR 10 days earlier and then had a rash, and she sent me a picture of it. I was like, that is from the MMR, and it's not dangerous. She looked happy. She was happy. So those are those are the main side effects.
So apparently there's some very rare brain condition that has been seen in like 3 people. Who got MMR.
Yeah. So there's a theoretical risk out there of some kind of encephalitis. It's not clear to me that that's causally linked to the vaccine. Right. But that is more like when they've calculated that even if it's a true association, it's less than 1 in a million doses. So I suppose that is theoretically possible, but very unlikely.
So but overall, it's much better to get the vaccine than to get measles. Yes,
without a doubt.
And the main reason for that is because of what happens after measles, not just the fact that, the vaccine is safe and any kid who gets measles is probably going to come out okay in terms of the numbers. But after the vaccine, you're protected for life. But after a measles infection, you're in fact susceptible to many other infections.
Yeah. So there are 2 reasons to do it. So the first is, what happens during acute measles, which we talked about, and it gets rid of your risk of pneumonia or the rare risk of encephalitis or things like that. But the thing that we understand now about measles that we didn't understand even a couple of decades ago is that having measles, not getting the vaccine, but having measles makes you more susceptible to other infections for about 3 or 4 years afterwards. And that's because the measles virus targets a receptor called SLAM, which is on memory B and T cells. So it ends up killing off your memory B and T cells, so you are less able to fight against infections, even things that you've either seen before or been vaccinated against before. And then you repopulate your cells and your antibody levels and stuff, but it takes a couple years.
So if I understand that correctly, there's a little bit of your immune cells are lower because the measles virus actually killed them off, but also some of the ones that are killed off are the memory cells, but it's not all of them. So you do regain that memory after that memory population has replicated and reestablished a larger population.
You certainly don't kill off the naive cells. So you still have the capacity to make memory B and T cells, and I think it's not 100% kill. There may be rare clones of memory B or T cells that you don't repopulate, but you rebuild your immune memory over time. I don't know that it's exactly the same.
So I think you mentioned in your book that at the height of measles, children were dying of other bacterial infections, for example, and that was taken care of by antibiotics, right?
Yeah. So again, there are two things with that. So during acute measles, you can get measles pneumonia, and then you can get a bacterial infection on top of that. That's something we saw pretty commonly during the 2018-2019 outbreak. And then there's this thing with immune memory, the immune amnesia, where it's a thing they now call the measles shadow. It's this like 2 or 3 year period after measles where you're more susceptible to other things like bacterial infections.
Do you think with the increase of measles in the U.S., there are a lot of cases last year, probably going to exceed that this year, we're going to start seeing these other infections in these children?
Yeah, I'm worried about that, and I'm also worried about about SSPE, like we talked about before. Like that's something that's a rare long-term complication of measles, but we're at a point where we will start to see those cases if we keep seeing big outbreaks like the one in Texas now.
You do a really great job, even starting in the first chapter, talking about how you talk with parents who don't want to vaccinate their children. So can you talk a little bit about sort of how you deal with that as a pediatrician?
Sure. I'll start by saying that I'm not a primary care pediatrician, and they are the superheroes. Like they are the ones who have these conversations over long periods of time. They develop relationships with families that last, years or decades. They develop trust, and they're really the ones who I think move the needle for parents and families who are hesitant. I have sort of a different kind of conversation because I only see kids who are hospitalized. And so those conversations tend to be a kid who's hospitalized with a vaccine preventable disease, having the conversation. Sometimes parents will ask if this was preventable. Sometimes we have the conversation. It's a conversation that can very easily go off the rails, though, because it is easy for parents to feel like they're being blamed, which is not what I'm trying to do. But I think how they end up framing what happened and thinking about what led to the hospitalization, what they're going to tell themselves, their kids, their friends afterwards is really important because some families had a child who was hospitalized during the measles outbreak in New York, and even if the child was in the ICU, their takeaway was, oh well, nothing really bad happened. Like we didn't vaccinate, and she got the measles, and now she's coming home.
They just take it for granted that the child is going to get better.
Right. And the conversation that I would try to have there is that, no, this was serious. This could have gone the other way. This is, something that is preventable. Let's have a discussion about the other vaccines. Let's have a discussion about how the thought process that got us to this point.
I don't know.
But it's hard. You have to be careful.
Going into the ICU is not trivial.
Agreed.
So if the parents think it is, that's a failure to educate, I think.
It's really interesting. There was a Washington Post article in the last couple of weeks. It wasn't about measles. It was about the severe influenza season that we're having. And they interviewed the mother of a child who was in an intensive care unit, was extremely ill. And at the end of the article, they circled back to her and asked about vaccinating against measles vaccinating against the influenza in the future. And she said, well, no, we never vaccinated against flu and we've always been fine. Which, of course, doesn't make any sense because this was not fine. And yeah, I mean, it can sometimes be difficult to communicate that. And it's not true for every patient, like for every family. Like a lot of parents are very, very frightened by having their child in the intensive care unit. I certainly would be.
Sure. So you write in the book that every single child diagnosed with measles represents a system failure. So what does that mean?
It means that we have had a safe, effective vaccine to prevent measles for more than 60 years. That says to me that there should be no more measles, that we should have eradicated it from the planet by now. And what it means, especially in a country where there's not a cost barrier, like we have the Vaccines for Children program. It's, any child in the U.S. has access to the measles, mumps, rubella vaccine. And if their insurance does not cover it, then VFC provides it. And that if we are seeing kids with measles, and especially if we're seeing kids severely ill with measles, it's because something has gone wrong. And either that something is we have a problem with vaccine delivery or access, or more often that we have a problem with how parents are understanding the value of vaccines.
Well, you point out this interesting situation where the measles outbreak in the 70s on the border of Texas and Arkansas, the disease follows political leanings, right?
That blew my mind. So this was an outbreak in 1970 in Texarkana, which straddles the Texas-Arkansas border. Kids were zoned to go to school in whichever state that their house was in. But there's a ton of mixing in the population, movie theaters, churches, things like that. And Texas did not have vaccine mandates. Arkansas did. Texas did not have government-funded vaccine drives. Arkansas did. And then when you tallied up the cases at the end of this outbreak, even though there's so much population mixing, about 95% of them were on the Texas side of the border and 5% were on the Arkansas side. Which, looking back, you're sort of like, well, of course, because vaccines work and school mandates work. But it was also that where you lived and the political decisions that were made in the state where you lived affected whether your kid got this potentially very serious disease. And I think there are echoes of that from COVID, where political party affiliation is an independent risk factor for death from COVID because Republicans were less likely to get vaccinated than Democrats were.
Well, the measles. The measles outbreaks have always followed like communities, right? People chat in their communities. Oh, this vaccine is no good. And then you have a whole bunch of people not vaccinating their kids, right?
Yeah. And that's exactly what we saw in New York. It's what we're seeing in Texas. Yeah, exactly.
So that's what we have to fix, somehow get in there. I mean, I was very impressed at some of these approaches that were used here in New York to try and get the right information to these communities, because they're getting the wrong information. So we somehow have to get the right. Public health needs to get the right information. We can't say you parents are bad for not immunizing your kids, but we have to say, here's the information. This is why you should be, right? As you say, in a calm way, and hopefully that goes well, because I just, as I said to you before, in the current administration, I have little faith that public health is going to do the right thing of that sort.
Well,
yeah. Oh, go ahead.
Go ahead.
I was just going to say, I think that that's right from sort of the upper echelons of public health. I still think there's a lot of value in community level conversations and that kind of outreach, even if the messages from HHS are not what we would like them to be.
I'm really glad that you talked about the 1970 outbreak, because I think things like that are, that wasn't something I'd heard of before looking at this. And it's such a clear example And I wonder if people sort of saw more of those obvious examples, if that might help convince them.
I hope so. It's so hard to deliver these messages because it's not that there's no good information out there. Like your podcasts are good information, and there are people on Instagram putting out good information sometimes. The CHOP Vaccine Education Center puts out good stuff. It's out there, but it's drowned out by this just fire hose of bad information.
But you give a really, I think, impressive example of having trusted messengers within a community that can help people from more of like a culturally relevant perspective understand how to evaluate the information that they're being presented with and see the value of the vaccines for their children.
Yeah, that was really eye-opening for me. That was, that's the story of Blima Marcus and her group called EMES. And these are Orthodox Jewish nurses who literally went from house to house, family to family, sat with people, answered their questions. If she got someone to think about vaccination, she would revisit the house. She would text the morning that they were going to take their kid to get vaccinated, see if they had questions, text them that afternoon to say, I hope everything went okay. Like this really hands-on, multiple visit kind of thing, which works. The problem with it, of course, is it's nearly impossible to scale. And it's not something that you can't send Orthodox Jewish nurses to the Mennonite community in Texas. That doesn't make any sense. They wouldn't be trusted messengers there. So it's something that has to be built locally. One incredible side effect of having written this book is I got to be friends with Blima Marcus, which is amazing. She's a force of nature.
Well, yeah, I just remember that they didn't even want you in their neighborhood, right?
Yeah, it was very, that was weird. So I gave a talk at a conference for pediatricians in the Orthodox community, and this was a couple years after the outbreak had ended, but we were revisiting vaccine preventable diseases, talking about measles, talking about other things that are reemerging, and there were protesters, including I have a picture of the protester who had my name on a sign saying that I was not welcome in the Orthodox community, which is sad. And I mean, I get it. I'm not a member of the Orthodox community, and maybe they felt like they shouldn't have doctors coming in from other places. But literally, all I was doing was one pediatrician talking to other pediatricians about pediatric diseases. It seemed pretty benign.
I think it's really hard to fight that, because I agree that you need to do this almost one-on-one approach, but there's a lot of resistance, and so I don't know how to overcome that.
Well, education, access to education about things that are related to your personal health at the college level for people from all different backgrounds. People, not just the ones who have the means to, and the personal family history of getting educated at a famous college, but really having a network of colleges that can teach people about these things so that people can go back to their communities and be those trusted messengers with the information and the critical thinking skills to advocate for their communities. Because we all, just like these parents, they do love their kids. They want to do what's best for them. And your perspective only changes with education.
Yeah, I mean, I think that's a crucial piece of this, which is that parents who are vaccine hesitant, parents who are anti-vaccine are not people who want harm to come to their kids. It is the opposite. They are making these decisions out of love for their kids. The decisions are based on wrong information, and we have to fix that. But it is not a question of anyone wanting to harm their kids.
So sometimes I think that, those of us who are pro-vaccine almost end up being in a little bit of a different bubble than those who are anti-vaccine. And there's a bit of a breach between the community. And you can think about the father whose child recently died of measles. and sort of the way that he talks about his community versus other communities. And so how do we breach that, and how do we actually help understand others to promote vaccination?
Yeah, it's really hard. And it was a very similar thing with the Orthodox community here. And I think it's certainly what we're seeing in the Mennonite community. And I think there's a lot of distrust of public health voices. There's sometimes distrust of anyone from outside the community. And I think that, that's part of why the public health approach has to involve community members before there's a crisis. Like I think this is hard because we're in an era where public health is starting out underfunded and likely to end up even more underfunded. But I think if you build those relationships over time when there's not a crisis, then when you go in, you're not a new face. You're not a new, you're not. It's someone where trust has been built. But that is slow and hard to do, and is something that will be, that is expensive, that governments aren't going to want to pay for.
So this Atlantic article is very interesting. Again, interview of the father of the young lady, the girl who died in Texas, and he says, "Why do people care about her now that she's dead? They didn't care about her before." So what? And so I don't know how to address that, because we're expressing a care that children should be protected, right? So how if you were to be able to talk to him, what would you do?
Yeah, I mean, I think the point of intersection, I think, between pediatricians and parents is that we both want the same thing. The parents come into that interaction wanting their kids to grow up happy and healthy. I come into that interaction wanting their kids to grow up happy and healthy. I didn't know the child in Texas. I care about her now and cared about her before in the same way that I care about any child. I want 100% of children to be able to grow up and be free of disease. I think you have to start there. I mean, it is hard, and that response, I think, speaks to distrust from the community of people outside the communities, and again speaks to the importance of public health folks building these relationships early and making sure that they're strong.
I mean, I'm trying to understand the mechanistics of this. So parents seek personal, religious, medical exemptions. So it turns out that no religion has a statement anywhere that says you can't get vaccinated. So that's just something that is used as an excuse. So I think there's a fraction of, I think maybe some of them are scared and they get misinformation and they don't know what to do. So they use these excuses not to get vaccinated. Do you think that's fair?
Yeah, I mean, I think that, so you're right. There's nothing in the Mennonite religion or in Orthodox Judaism or in anything else, with the possible exception, I suppose, of like Christian Science or something like that, where they say no to all medical procedures. But there's nothing in any of these things that says that vaccination is prohibited. It's, from what I've heard of what has gone on in the church in Texas, there were pretty strong anti-vaccine sentiments there, but there wasn't a prohibition. And I think it's hard because I think you have parents who, even outside of those communities, there's so much information out there that's raising questions about vaccines. And then these are, for the most part, the father of that child was in his late 20s. Like, this is someone who's grown up in an America where measles has been eliminated. This isn't someone who has any direct experience with measles. And that's true of most parents now. And it's certainly true of polio. Like, most people who are parents now are not people who remember when there were polio outbreaks in the United States. And that lack of direct experience, I think, is meaningful. And so you could understand in a parent's mind where they're like, okay, there are all of these people saying that the vaccine is dangerous. It's protecting against a disease I've never heard of or never known anyone with. Why would I take a chance? And the answer is, of course, you're taking a chance when you decide not to vaccinate. But that's hard to communicate.
It's interesting that, when we're thinking about how to approach this, we are usually focused on the numbers, as we scientists are, and the technicalities. Sure. No religion has a statement that says that they are anti-vaccine, but that's not the thing that people are thinking when they're making these decisions, right? They're thinking more on the emotional side of things and more on the story side of things. So some of the stories that you have in the book are really powerful, even though they are these N of one. They are very representative, and I wonder if the kinds of communication that we do can be adjusted to help with what people are going to connect more with. If our goal is to connect with them so that they can understand, as opposed to convince them that we're right because the numbers say we're right. Maybe that will be a way to help with a lot of these challenges that we're going to have as we go forward, where we have these regular outbreaks and our response, especially with the current administration and the leaders that are not really willing to either one, admit that there's a problem, or two, respond in the way that we know is going to help people, if that will help us help other people save their kids.
Yeah, parents care deeply about the N of one because they care about the child they brought in. They are not necessarily thinking about the community around them or the country as a whole or the world as a whole. One of the reasons we vaccinate is to protect the person getting vaccinated, of course, but also to do your part to protect your community. And that's something I talk about sometimes. But yeah, sometimes stories like that help. It's hard though, because for a lot of the diseases we're talking about, even the doctors who are telling the parents, yes, you should do this, haven't seen these diseases. Like, and even if you're talking about someone who has seen measles, they probably haven't seen much diphtheria. I haven't. I mean, it's there are things that are gone because we vaccinate them against them, and they stay gone because we continue to vaccinate against them. But I will never be able to tell. I hope never be able to tell a family about all the children with diphtheria who I've seen. So, I mean, I think what you might be able to do is tell a story about a family that decided not to vaccinate, and then their child got a different vaccine preventable disease, and just sort of how difficult that was for the family and the guilt and it's like you can try to make them go down that sort of train of thought, but it's hard. And you're right. It's very different from saying, if you get 2 doses of measles vaccine, there's a 97% chance that you are protected against measles for life. Like that may not be so interesting.
So do you think that, I think we're going to have a lot of measles cases this year and a lot of deaths. Do you think, so will there be a point where these individuals who have never seen measles and can't understand its impact will suddenly see throughout the U.S. a lot of morbidity and mortality and say, oh, maybe I should think about vaccination after all?
I mean, I think we've seen some of that in Texas now where, not everybody, but there have been a bunch of families who have decided to get vaccinated because they see that, rather than something theoretical, that this is something real. I think having a child who died there was frightening to a lot of people, both in Texas and outside of Texas. That is something we haven't seen in the U.S. in many years, a child dying from measles. So I think for some people it will move the needle, and for some people it will not. And some of that is that, for some people being anti-vaccine is wrapped up in their identity, their political identity, their social identity, and that can be very difficult to crack.
So you mentioned a second ago that if you get a measles vaccine, 97% you are protected against measles. We talk about you getting vaccinated and getting protected, but as we learned during COVID, there's some misunderstandings about exactly what that protection might look like in terms of, prevention from severe disease versus prevention from any infection and things like that. So how do we sort of give the transparency that we might need about this and not let the details start to hurt us?
Yeah, it's a reasonable question. It's it's a little easier with measles because I think that the 97 number actually is protection from disease entirely. And probably in the 3%, you're better off having gotten the vaccine than those 3% are people who don't have the same level of antibodies, but it's not like they have zero response. They may still be able to get a rash. They're very unlikely to die from measles. So I think that it's, there's the 97 and then, and that is good. And then there's the 3 where they might still get a rash, but they're very unlikely to die. Like when you look at people who die from measles, who end up in the intensive care unit with pneumonia from measles, these are unvaccinated folks. So it's a little bit easier a story to tell from the point of view of measles vaccine, but your point is super important. And it's not a guarantee, and that is the reason that we have to vaccinate everyone, because measles is super contagious. You need to vaccinate more than about 95% of the population. But once you're there, if measles isn't circulating, by vaccinating everyone, you've protected that 3%, and you've protected the kids who are too young to be vaccinated, and the kids who are getting chemotherapy and can't get a live vaccine, and like all those other folks.
I love the example in the book that you give of how measles is similar to rinderpest. And rinderpest is one of the only other diseases in the world that we have eradicated. And so there is actually the possibility that measles could be eradicated. And that's one of your major calls here, is that we should make that a goal because it's possible.
It is absolutely possible. I think we're unlikely to get there anytime soon. I was more optimistic when I wrote the book than I am when the book is coming out, because I think it is something, measles eradication is something that we could do, but it would require many nations pulling in the same direction. It would require investment. It would be amazing in the same way that smallpox eradication was amazing. It would be, this enormous feat that would eventually allow us to stop vaccinating against measles. You wouldn't have those 100,000 deaths a year that we have now from measles. You wouldn't have all the morbidity that goes along with it. And I can dream.
So, eradication requires the U.S. to participate, right? I can't see a world where we do an eradication campaign and the U.S. just sits here, because that's what I think it would do in the current administration, unfortunately. So, so maybe in 4 years we can dream about that.
Yeah.
I really like the Faroe Islands chapter, having taught that for many years. And I really like this.
Yeah, in fact, I am sure that I am using that chapter in classes from now on. I really love that chapter as well.
It was so much fun to write. I can't even tell you.
And a big part of it was talking about the miasma theory of disease, where, at the time of that outbreak, we didn't know anything about bacteria or viruses. We just knew that people got diseases, and they were trying to figure. And so this idea that miasma, bad airs, caused it, fell out of favor shortly afterwards, end of the 1800s, right? And so what killed me is that we have someone who's the head of Health and Human Services who believes in the miasma theory, does not believe in the germ theory of disease. And it has been so thoroughly debunked and disproven. I'm just shocked.
Yeah, I have no answer to that. I agree with you. I too am shocked, but I think that it's, there's this devaluing of expertise. There is this non-belief in science that is pervasive. And I think that, you and I, all of us want to use scientific arguments to convince people of things, and they don't buy the very premise of the way that we're putting the arguments forth. And that's really hard.
But Adam, we have a guy who gets in front of Congress and says miasma, and everybody is nodding and voting yes for them. Nobody is able to say this is BS. I just don't get it.
I don't get it either.
All right. And in fact, even worse, this week, NIH rescinded funding for NIH proposals that study vaccine hesitancy. So here we are. We're trying to figure out how to deal with this, and you can't formalize it in any way. What do you think about that?
It's horrible. I mean, we need to understand why people are hesitant about vaccines. Vaccines are one of our greatest public health achievements. Children live longer today than they did 100 years ago or 50 years ago, in part because of vaccines. And we should, studying vaccine hesitancy isn't against the people who are hesitant about vaccines. It is a way of figuring out how to help people who are hesitant about vaccines and how to provide the information that they need. And I don't understand why you would stop funding that.
So if we're also talking about recent things with the head of HHS, I was wondering if you could talk a little bit about things like vitamin A and cod liver oil and how you might address a patient who was sort of thinking about going that route.
Sure. So as with many things that Kennedy talks about, like there's this one little kernel of truth in what he's saying. And there is an interaction between vitamin A and measles. And I'm happy to talk about that. But then it gets extrapolated into all kinds of crazy. So I'll tell you what's true about vitamin A and measles, and then we can talk about the other stuff. So kids who are malnourished are at much higher risk of dying from measles and of getting severe disease from measles. And specifically, kids who are vitamin A deficient are at high risk for those things. And if you supplement vitamin A, we have randomized controlled trial data on this from the 70s and the 80s. If you supplement populations with vitamin A, you decrease the death risk from measles. So that is all true. The WHO recommendation for vitamin A in the setting of measles is that all kids with measles should receive 2 doses of vitamin A under the supervision of a doctor. So this isn't long-term vitamin A, with the idea that it would decrease the risk of severe illness and death. In the US, where the rate of vitamin A deficiency is very low, I think it's unlikely to have the same level of effect as it has elsewhere. But fully reasonable people would say here that any kid with measles should have 2 doses of vitamin A prescribed by a doctor. That is 2 total doses. And that's a reasonable thing to do. Other people would say, we'll do that for the kids who have severe illness, who are hospitalized or something like that, to make sure it doesn't progress. Fine. That's a reasonable way of doing it also. What vitamin A cannot do is it does not prevent measles. And so what you're seeing online are tons of people saying, oh, just take vitamin A instead of getting the vaccine. That makes no sense. Cod liver oil indeed has vitamin A in it. That is true. But it has no role in preventing measles because even purified vitamin A doesn't prevent measles. And if you take vitamin A or cod liver oil for long periods of time, especially if there's no regulation of the dose that you're taking, you risk getting hypervitaminosis A, so vitamin A toxicity, which can be really serious. That can give you, it's a fat-soluble vitamin. It concentrates in the liver. You can get liver failure from it. You can get bone issues from it. There are serious things that can happen with kids who get vitamin A toxicity. So I think on balance, it's, if your kid has measles and you go to the pediatrician, it is reasonable for the pediatrician to prescribe the 2 doses of vitamin A. Short of that, nobody should be giving their kid vitamin A or cod liver oil or anything else like that to ward off measles. The only thing that wards off measles is the MMR vaccine. End of rant.
Also, cod liver oil has a very low amount of vitamin A. It's not even clear you would get enough from that, right?
Yeah, I don't know, and I don't know how much variability. I've never really been asked that before. I don't know like how much variability there is in different brands of cod liver oil. No idea. Like you're choosing not to do something with a known amount for a period of time that we know is safe, to do something with an unknown amount for an unknown period of time.
I wanted to ask you your thoughts on medical exemptions. So in the Texas outbreak, the medical exemptions are at 14%. And I was told once it should never exceed 1%. That's about what you would expect across the U.S. So that means some doctors are giving medical exemptions when they're not warranted. So I thought doctors are trained not to do the wrong thing. I don't get it, Adam. Explain this.
I thought, so I may be wrong about that. I thought that the 14% was the total exemption number, because there are non-medical exemptions in Texas. So it may be that that's the sum, but you're right. So there is a problem with some doctors doing that, though. I'm not here defending that. So like if you look at California, for example, where, after the Disneyland outbreak, they did away with non-medical exemptions. All 50 states have medical exemptions are possible, as they have to be, because like if you're the rare child who has an anaphylactic reaction to something that's in one particular vaccine, you obviously shouldn't be forced to have that vaccine. Okay, so there are medical exemptions. Non-medical exemptions, some states like New York don't have a path to any non-medical exemptions, religious or personal exemptions or whatever. California did away with non-medical exemptions after the Disneyland outbreak in 2014, 2015. And what they saw was really interesting, which is that before that outbreak, the rates of exemptions, and they were mostly non-medical exemptions, were clustered in certain parts of California, and it was in large part sort of rich areas near cities, and medical exemptions were not clustered in the same way. So then SB 277 passed, which was the thing that got rid of non-medical exemptions. And what they saw was that the medical exemption rate both went up and clustered in exactly the same way as the non-medical exemptions did before before SB 277 was passed. And so that was, some number of doctors deciding that they were going to give medical exemptions to people who probably didn't really need them. And so now they passed another thing where they put a cap on how many medical exemptions a particular physician can do before each one gets reviewed by the state board. And there are other things you can do, but it's a concern.
It's probably not really possible to legislate your way completely out of the issue, because you're really just maybe encouraging people to go around things.
Yeah. No, I think education is better, right, as we've been talking about. Yeah. I noticed, and I didn't know this, I didn't realize that JFK was a big vaccine proponent.
Absolutely. Yeah, and he was the reason that that measles vaccine got included in some federal financing early on. He was a fan.
I just wish he were still alive and he could talk to RFK Jr. and say, "What are you doing?"
Yeah.
Right?
Yeah.
What do you think about vaccine mandates, Adam? We used them in COVID, and many people think it backfired. So what do you think?
Yeah, I think there are two different kinds of mandates. So I think the mandates that people are most upset about from COVID were kind of employment mandates for adults, and they were widespread. And you're right, they were certainly unpopular. I don't think they were unreasonable at the time. I don't think there was a sense that those were going to be around forever. School mandates are different. School mandates are really, really important. We have seen, again and again, and the Texarkana thing that we talked about is one example of this, that you need school mandates to get to 95, 97% vaccination rates, which are the rates that we need. And, some of that is just as a nudge for parents to get their kids vaccinated because they have to for the kids to be able to go to school. Some of that is that it keeps local and federal governments honest because you have to be able to provide those vaccines if you're going to mandate them for kids to go to school. I think that there are moves in many states now to try to do away with mandates for the routine vaccination schedule, and I think it's a mistake. And you can, I think that there are mandates for certain vaccines, but there are others on the schedule that are recommended that I think it's harder to mandate. In a lot of places, there's been refusal to have mandates for human papillomavirus vaccine. I think everyone should get vaccinated against human papillomavirus. Of course, it's a harder sell that that's a school safety issue, or that something like there's like things that are less contagious than measles may be harder as a sell. I still think they're useful. I still think that they should be part of the equation, but I think especially for things where you need very high vaccination rates, they're crucial.
Yeah, I think that part of the problem with all of this was something I hadn't fully recognized until I was reading this, where you talk about all of the situations where people were very complacent about measles and thought that it wasn't a big deal. You talk about the Brady Bunch episode, and you talk about, asking your mother if you could have measles next because it was a ability to relax. And you've also mentioned, parents even now sort of saying, oh, that wasn't a big deal. And so I guess my question is, how do we sort of emphasize that this does matter and that we need to have people worry about this? And how do we combat that kind of complacency?
Yeah, it's really hard. I mean, you can point to, what's going on in Texas and the child who died. That's, I think a stark reminder. It is sad that it has come to that. But I think this is, this is the problem with not just vaccination, but this is the problem that all of public health has, which is that, when prevention is doing its job, it just looks like regular life, and people forget why you're trying to prevent things.
So do all states currently have vaccine mandates for school entry?
Yes, they're under threat in a whole bunch of states, but as of now, my understanding is all 50 states still have vaccine mandates for school. Some of them are only a very few vaccines, but
yeah,
these are mandates for public schools.
Yes, correct. So there are places where people homeschool to get out of those mandates.
Mm-hmm.
And there are also private schools, and they're not bound by the same regulations.
Yeah, I'm not sure if that's a state to state thing. I don't know the specifics of that. I think there are some states where that it may be that they are, but I'm not sure.
One of the vaccines that is essential, yet RFK Jr. and the guy who just stepped away from
Weldon,
head of CDC, they don't think babies should be immunized with HBV vaccine. They say, oh, it's a sexually transmitted infection. They don't. What, do they not read the literature?
That's correct, Vince. They do not read the literature. Yeah, no, it's ridiculous. Like, hepatitis B is a cause of chronic liver disease. It's a cause of liver cancer. It is frequently transmitted in the peripartum period, like right around birth. That is why you vaccinate newborns. That is why we check hepatitis B status in pregnant people during pregnancy. And, what we've seen from other countries is that if you try to vaccinate at later times, you miss people. And if you don't prevent that perinatal transmission, it is a lifelong infection, or it can be, and it can lead to, liver failure and liver cancer. It is no joke, and it is a reasonable thing to vaccinate against.
In fact, if you're older, I don't know the age, but when you get Hep B, it's more likely to be resolved and not be chronic. So it's immunizing older people is not even a necessity, but it's the babies that have to be immunized, obviously.
Right.
It's crazy. It's just crazy stuff. Oh my gosh. One of the One of the topics in the book is the anti-vaccine movement surrounding IPV and OPV, which was considerable right after the Qatar incident.
Yeah. That was, that was something where it was reasonable for people to be concerned at the time. So it was right after the Salk vaccine trials and the demonstration of how well the Salk vaccine worked. And there was a big push to get the vaccine out to everybody. And it wasn't just one pharmaceutical company. It was licensed to a bunch of different companies to try to be efficient and get things out. And at Qatar Labs in California, there was a batch of vaccines that was insufficiently killed and caused polio in a number of children who received the vaccine. It was a horrible tragedy. Paul Offit writes about it wonderfully in his book. And I think it's actually remarkable to me that didn't cause more of a crisis of confidence in the polio vaccines overall. I think that there was concern at the time, which is reasonable, but for the most part, the country got back on board with polio vaccination. But it was it was an early thing where there were lawsuits and there were questions of liability for vaccine companies, and there was the seeds of the anti-vaccine movement.
Oh, I mean, everybody was dying to get polio vaccine, right?
Yeah.
They lined up, they trusted the system to serve them, and then it fails on the first big try. It's the worst possible thing that could have happened, right? Because as you said, that's really seeds anti-vaccine sentiment big time. And then there's this other issue that you point out that now if you make a vaccine, you're still liable, even if you made it perfectly.
Yes.
If somebody gets injured, right? And so that's product liability, which then spread to everything else, including toothpaste. If you make great toothpaste and it hurts someone, you're liable for it. It's crazy stuff.
Yep.
Any other questions?
Well, I was just going to ask if you had any comments. I think that we all know the big picture answer to this, but what your comments were about people who talked to you about measles and autism.
Yeah. So, I mean, I'll start by saying that there is no link between measles vaccine and autism. And it's, this is something that we've been fighting against for decades now. There was the Wakefield paper in the late 90s where it put out the hypothesis that measles vaccine causes autism. It was that's a scientifically addressable hypothesis that was then addressed with large studies, tens of thousands of children, multiple continents. There is no link between the MMR vaccine and autism. And yet this idea persists. And in part because it provides a simple explanation, a 3-word explanation for something that's hard to explain. Like if you go to your pediatrician and you say, you're telling me that vaccines don't cause autism. What does cause autism? And a good pediatrician will say, well, it's complicated. Like there are genetic causes of autism. There are probably environmental causes of autism. There are certainly infectious causes of autism, like congenital rubella is one of them. But by then you've lost the family. Like they're not interested at that point. Like that is a much more complicated answer than the 3 words vaccines cause autism. And we, this is, I think, emblematic of the information battle that we are struggling with.
That started with thimerosal, right? And the idea that thimerosal was somehow
right. I mean that they were overlapping in time. So RFK Jr. had an article about how thimerosal was causing neurological diseases, and
so now it's been removed.
Also not true.
So you can't, and autism rates continue to rise.
Yes.
So they can't deal with that anymore, right?
Right. So they moved the goalposts again.
Well, RFK still talks about eating tuna fish sandwiches and getting toxic amounts of mercury. It's ridiculous. Just ridiculous. Jolene, you have anything else?
Yeah, I think in the introduction part of your book, you have a really powerful story about a child in the hospital and you go in to have the conversation. And this is something you've had many times, the conversation with the parents about why they're there. And you talk about leading with curiosity to ask them what their experience has been. And you also talk about having multiple conversations over days. And so I wonder if you can think about the listeners and the readers who are now getting to read through the story of the book, and how you characterize measles and our infections with measles as characteristic of the way that we have experienced it as a society, and how we have not fully taken advantage of the vaccine. So if we were to go out now to be talking to people and we encounter ourselves with individuals who are not vaccinated, can you tell us what's kind of your tips approach for how to have that conversation in a way that can really make a difference?
Yeah, it's a different conversation for each family, I think. And it's that's the whole lead with curiosity thing, is I really do want to understand what has brought people to that place where they are either hesitant about vaccines or against vaccines. And for some people, it may be, I've heard that the MMR vaccine causes autism. And so that's a conversation you can have about scientific studies and facts. There may be someone else who says, I think we're just giving so many vaccines now, and we didn't have this many vaccines when I was a little kid, and I don't understand that. That's a different conversation. I'm just so scared because last time he got a vaccine, he had a fever for, 2 days afterwards, and it was a miserable couple of days. That's a completely different, So I think I think there's not a one size fits all thing. And I from a public health standpoint, I think that people try to put out information that counters the misinformation that's out there. And that's really important, but it doesn't necessarily work for every family, because that may not be the thing that they want to hear. So, or that they, the thing that they need to discuss. I think that's the kind of thing that general pediatricians do really well, because they'll get to know the family. They'll have that conversation. The family will come back in 2 months for their next visit or something. They'll revisit it. But it's hard. It's slow. And like the thing with the nurses, it's hard to scale.
Vincent and I both mentioned how much we liked the Faroe Islands section. And I can't say enough about it.
Thank you.
And so what was sort of your favorite part of writing this, or favorite thing that you learned in the process of putting together this book?
In that section, or just
No, in
overall?
any section. I'm sure I learned a ton about the Faroe Islands that I didn't know about, and I'm guessing you probably learned about some things in this process too.
Yeah, I mean, it was a bunch of different stories like that. It was things in the history of measles that I didn't appreciate. I think that I would say the main theme that I think shocked me the most and changed how I thought about things the most was what you brought up earlier, which is about social determinants, and just that overlap of poverty and colonialism and measles and outcomes, which just kept coming back. I felt like that gave me just a much more nuanced understanding of this disease.
I was also very impressed with how you worked that in and how you talked about that. So
thank you.
Congratulations on that.
Thanks.
So Adam, what's going to happen in the next years? We've already said there are going to be a lot of measles morbidity and mortality. Are any other infectious diseases going to jump up as well, you think?
Yeah, I mean, I think that's the whole thing with measles, is it comes first because it's so contagious. So it is a bright red warning light for what's going to happen next. And so, I'm worried about West Texas now because and there's measles there now, and we have to deal with that now. But I'm worried about, pertussis in that community, whooping cough. I'm worried about reemergence of things that we haven't thought about in a long time. I've seen in the last 3 years, 3 cases of Haemophilus influenza type B, Hib, bacteremia, and meningitis in children. This is something that was a huge problem in pediatrics up until the late 1980s. There was a conjugate vaccine licensed in the late 80s, and by the time I was a pediatric resident in the late 1990s, I saw 0 cases from 98 when I started residency until 3 years ago. That's a good long time, and now I've seen 3. And that's because people aren't vaccinating against it. All 3 were unvaccinated kids. So I think I think these things that have become unfamiliar are sadly going to become familiar again.
I think we're going to see polio also.
Yeah, I think you're right.
We had already that case in Rockland County, right?
Yeah.
In an area with very low immunization rates. So I think that's going to happen elsewhere as well, especially when we don't have encouragement from leadership to have programs to encourage, the Betsy Bumpers incident program that you talk about in Arkansas, she and her husband, who was the governor, right? They put together this program to get measles vaccination and mandates for school entry. And then the Carters said, this is great. And they were approached by the Bumpers, I guess. Yeah. And they did it for all 50 states.
Yep.
And I just don't see that happening today.
Yeah, and I mean, it's not even just the vaccine promotion. Like, I'm worried about our ability to do disease surveillance. So it's good. Like, we found out about the case in Rockland County, the polio case, because that person had paralytic polio. But then there was really important wastewater surveillance work in both Rockland and in New York City. There was, polio in the wastewater in New York and in Rockland. There were many people infected, I think, and it's just that we had the single case of paralytic polio.
Yeah, well, we're lucky that overall immunization rates are pretty good for polio.
Yep. And so I worry that it's not just that people won't be vaccinated, it's that CDC and local public health departments won't be able to do surveillance in the way that they should.
Well, I think if states eliminate mandates for school entry, this polio vaccine is one of those, right? So
yep, absolutely.
That's going to be a big disaster. So, Adam, do you have any other plans for another book?
I totally want to write another book.
Oh, yeah.
I'm not 100% sure what, but I think given the era that we're coming into, it's, it'll be on similar themes.
I think that the great thing about having a book like this is it's a really great dive into history. And that's one of the things that you mentioned, that the history, revisiting the history of what was bad and what is good, it can be very inspirational to us. And so having more of these is maybe one of our hopes to keep on an improving trajectory.
Thank you. Yeah, it's one of the things was that most of this book was written during the COVID pandemic, and it was, it seems crazy because I was like working in the hospital and taking care of patients with COVID, and then coming home and like reading 19th century accounts of measles outbreaks. But it was therapeutic for me. Like it made me feel like we were not alone, that like we had done this before. I think the history is important.
That's TWiV 1201. You can find the show notes at microbe.tv/TWiV. You can send your questions and comments to TWiV at microbe.tv. And as I said before, we'd love your support to continue these programs, microbe.tv/contribute. Our guest today, now I hear a siren.
Yes, I hear the sirens too. Sorry about that.
No, it's
New York City.
Yeah, it's fine. Our guest today, pediatrician Adam Ratner, author of Booster Shots. Go buy it. It's really good. You'll learn a lot. Thank you, Adam, for joining us. Really appreciate it.
Thanks so much. This was terrific.
Brianne Barker is at Drew University. She is BioProf Barker on Blue Sky. Thank you, Brianne.
Thanks so much. I learned a lot. This was great. Thanks so much, Adam.
Thanks.
Jolene Ramsey is at Texas A&M University, ramseylab.vercel.app. Thank you, Jolene.
Thank you. And Adam, the book was a real pleasure to read, and I look forward to sharing it with other people.
Thanks so much.
So, Jolene, when you listen to a book, is that reading?
Absolutely.
100%.
I listened to Adam read me the book. So
there you go.
I'm Vincent Racaniello. You can find me at microbe.tv. I'd like to thank the American Society for Virology and the American Society for Microbiology for their support of TWiV Ronald Jenkins for the music, and Jolene Ramsey for the timestamps. You've been listening to This Week in Virology. Thanks for joining us. We'll be back next week. Another TWiV is viral.